How health systems work. I'm your host, Jim Burke, and I'm here with my co-host, Steve Pratt.
Hello, everyone. Thanks for joining our show. We have with us Brian Betner. Brian's a partner at Hull-Render, been practicing healthcare law for a long time, and spends a lot of time working with hospitals to try to improve quality of care.
Yeah, Brian's just a great guest to have. He really brings an amazing insight into the quality aspects of that value-based transitions.
Stay with us. We hope you'll enjoy our guest, Brian Betner. Brian, tell us a little about yourself.
It's fun to be here, I'll tell you that. As you said, I've been Hull-Render now for I guess this would be my 21st year, and came straight out of law school. I went to law school straight from U.S. Navy, Hoo-yah, and had a great experience with that. I will tell you, when I was in law school, I had no idea what healthcare or health law was, right? I had a professor, a titan in the industry. I mean, plates would levitate when she'd walk in the room. And that was Eleanor Kinney, Steve. And so I learned a lot from her, was an RA from her, and went all in. Concentrated. I didn't get to take rock and roll in the law or all those kind of fun because I went all in on every kind of bit of healthcare curriculum, and it's been fun ever since.
And really an amazing career since, Brian. Back at the first health system I worked for, HSHS, I knew Brian Betner's name. That was probably 15 years ago, and you were considerably earlier in your career, and you were still, even at that time, you were well known as a medical staff expert. The person that we'd go to, forget Horty Springer, forget Greeley. If you can get him, go to Brian Betner, right? And we have a client that has nicknamed you the Brain. You really do, and that's a true story. So I'm not making that up on the spot. And you really do have a lot of details socked away in that head of yours. But we're here today to talk a little bit about how health systems work and what's changing. And you're at the forefront of some of that change. Steve and I do a lot of work together on value-based enterprise, value-based care initiatives. You have a unique perspective. You have a really solid quality background. How did you end up focused on quality? Did that come out of that med staff work, or how'd you get there?
It did. When you represent medical staffs and their leaders and the liaisons to them, the chief medical officer, chief clinical officer, and administrative teams and whatnot, and you're looking at what they're trying to do, and you deal with a lot of quality and conduct issues, that starts to unravel really quick to understand, well, what is the issue we're talking about here?
Right?
You see the worst of the worst, and you see the best of the best, and everything in between. And then that starts to get to the foundational issues. What's the purpose? Why do medical staffs even exist from a statutory standpoint? What is their purpose? And once you understand that, then you actually get into what are they doing? And then invariably you spend a lot of time talking about the actual peer review processes, the goals, the objectives. What are the standards? What are not the standards? There's a lot of autonomy in this sort of issue. And if we really look at that, then what are we trying to do here? And how do we actually advance the ball? What's the organization trying to do?
That's a different approach to value-based care than what I'm used to. My umpteen-year career in-house was approaching value-based care as a relationship building between the organization, the hospital, the health system, and physicians. And I would, Steve Pratt was my go-to attorney on these types of transactions, the compliance issues, the regulatory framework, how we actually built a system that would give incentives that aligned everybody. But you're approaching it really from, a lot of times I felt like we ended up at quality. You're starting with quality.
And why is that, Brian? Why is quality that important?
Well, because that's why hospitals exist. They exist to provide optimal patient care. I mean, we tend to look at this. Everybody has a system brother, aunt, uncle, mother, child, sibling. And sometimes hospitals get caught up in understandably so, in the business operation. When, if you reverse engineer it a bit, the most high-performing health systems and hospitals figure out how to reverse engineer that back. How are we delivering care? How are we touching patients? How are they experiencing us? How are we earning not only accolades vis-a-vis measures, campaigns, leapfrog, etc., but then the brand awareness and community support that then comes from that. I mean, word of mouth is more powerful than any marketing campaign that can ever exist.
One of the big pressures in healthcare today is cost and controlling costs. So how do you reconcile the desire to control costs and deliver less expensive care with the commitment to deliver higher quality care?
Healthcare delivery, the design of delivery follows reimbursement policy as a practical matter. Hospitals have to keep their lights on. They've got to hire people. They have to be able to fulfill the roles and execute on those sorts of things. So it is always a challenge to try to design any service line, any kind of even macro level delivery, if we can't do it in a way where the organization is going to make money and get paid. With physician leaders, the expression I use all the time is, there's no CPT code for that. And what I mean by it is a lot of these things we ask of physicians and physician leaders, we don't get reimbursed for. Why are we doing it? What the benefit of it is. And if you think bigger picture than just quarterly report approach, if you're willing to invest in something that takes a little bit more time, the return on the investment can be significant, whether it be the financial models that you've affiliated with a commercial payer or a governmental payer to maximize that. But you have to look at the tier 2 and tier 3 things like physician engagement. Physicians love to be stimulated with regard to how can we deliver care in a better way. The retention that comes with that, the ability that we are actually managing physician operations in a way that recognizes why they went to medicine in the first place, which is to provide
Connect
care.
that to the initiatives we see our clients doing. And you get called, your practice is really developed into far beyond medical staff quality issues and regulatory issues and licensing issues. You're pulled into transactions. You're pulled into strategy. You're pulled into really structuring the relationship with physicians. And as we look at the initiatives that we see in value-based care, whether it's restructuring a service line co-management agreement. You and I worked on one of those together, right? Whether it's direct to employer, whether it's starting a provider-sponsored MA plan, whether it's team-based care compensation and in a pooled compensation, whatever these initiatives are, we typically say we need to make sure that we align incentives and pay physicians, and you come at it from a different perspective. You say we need to align quality. We need to let physicians lead in quality. Talk to us about kind of the practical application and where we fall short in health systems and hospitals when we talk to physicians about these initiatives.
So for me, it starts with, can this actually work? And how will it work? And will it work? And that takes into consideration the typical, what happens in the hallway at a typical hospital on a Wednesday, how physicians navigate it, what they do. We can design a lot of things conceptually that are really academic, but if it doesn't meet how clinical operations actually work, and if we're frustrating the participants in this, and we claim all these big aspirational concepts and the recitals of an arrangement, but we haven't put the infrastructure in place for that, in fact, to work. That's the big gap I see. So a lot of hospitals have a quality strategy. The board adopts it. It gets posted on the website. I rarely see that quality strategy, whether it's kind of big picture and kind of categorical, or whether it's even granular, these things we want to achieve in our community. I rarely see those actually flow downstream to the physician agreements, the incentives embedded in the employment and the PSA. And so how do you have a quality strategy that sits here? I mean, it's polished too. We might get an award, the Kennedy Center honors kind of thing. But bricks and mortar do not deliver care, right? And so how do we take that and influence the way a random physician is going to interact with a patient, care for a patient, interact with the program, the system, the processes? How do we connect those two? And an employment agreement or a PSA or kind of a larger scale co-management or a VBE, if it doesn't actually get to how they do it and we've connected the strategy, it's a big disconnect. We say our goals are A, B, and C, yet we incentivize D, E, and F. you're never going to meet those goals. So it's really aligning what we're really asking physicians to do. And candidly, it's a combination of asking, encouraging, and even pushing. I mean, clinical leaders have very broad latitude today in what they actually require to practice within a facility. But that hits political headwinds real quick.
I use the value-based enterprise rules a lot in my practice to try to drive the change you're talking about. So talk a little about how you use those rules. Well, first of all, what are they, and how do you use them to try to push hospitals and physicians to improve quality?
First and foremost, Steve, let's simplify what we're talking about. What really is it? Don't get caught up in so much in the acronyms and those sorts of things, but if you really understand it, which is one of the more frustrating aspects of any sort of arrangement, regardless of whether it's an employment agreement, service line arrangement, a VBE that is both or neither, is that oftentimes the business leads or the clinical leads that are being plugged into it don't understand it. So therefore, they don't know how to navigate it and adapt to it. And it might just be as simple as your license and your clinical privileges allow you to practice in a very broad way. You have tremendous physician autonomy. So in some respects, a VBE, if we separate the dollars from it, we're going to narrow your autonomy to just practice with regard to this population in a specific way. It could be complicated, but it can also be very narrow. You will always do a surgical workup this way. You will always engage the patient this way. You will always document it this way. We're going to use quality payment program measures or anything otherwise plugged into Meaningful Measures campaign that's also recognized by payers. That's what we're going to baseline. That's what we're going to track, and we're going to coach and teach around it. A lot of organizations, when you apply for membership and privileges, whether you're employed or under contract, it's good luck out there.
It does seem to happen that way frequently.
So, and Brian, I want to stop you there and ask, because that's one of the things that I see in some of the VBEs we've been doing at Hall Render. We get to this point where we kind of hand it off and expect the physicians to somehow collaborate on care pathways, on order sets, on a collaborated way of approaching common problems with patients, and your problem list, right? And so we're gonna take this diagnosis and we're gonna respond in this way. Do you see physicians ready to do that? Do you see physicians willing to do that? I mean, they're independent to a fault. They're the smartest kid in the room. We know that, and they don't want to be told what to do. And yet they want what's best for patients. We know that from interacting with physicians. They want what's best for patients. Are physicians ready to give up some autonomy to come up with these care pathways, to come up with these order sets, to come up with this plan of care that's standard for certain conditions?
The biggest gap I see coast to coast, I don't care if we're in Portland, Oregon, to you name it, in Miami or Pittsburgh, Pennsylvania, it's that I can always identify a highly motivated clinical leader who loves this stuff. They get geeked out about quality issues. They stay up late on Reddit feeds. But that's an anomaly. The gap is knowledge and training. Providing the sort of, and I'm using those terms loosely, but providing physician leaders and the participants in these endeavors with the skills and the understanding, so they're not doing homework at 10 p.m. trying to figure it out. So a lot of this can involve teach to the test in it. There's a shared, the hospital and physicians, whether it's a group of physicians or individual physicians in the hospital, they absolutely have a shared interest. And the Venn overlap is significant. And we can teach to the test and invest in that so that there's a lot of buy-in, rather than like, hey, develop 3 clinical pathways related to this chronic disease state, and let's see if it works. Like, how can we assimilate it into hospital operations? Does it work with our EMR? Do we have the tools to even track it? Do we report on it? Can we give you actionable feedback? The biggest, so when you talk about feedback and reporting on it, every hospital in the country, whether you're Joint Commission accredited, DNV accredited, ACHC, requires some version of FVP and OPPE. Forget employment agreements, forget like just to have privileges and exercise it. In which we evaluate care and we give physicians feedback on that care across 6 competency domains. Most of those, even with our most sophisticated clients, are rudimentary at best. Rudimentary. It's low-hanging fruit. It's whatever the EMR was built out to pull so we can run a report, but it may not mean anything to the physician. They might not be able to act on it even. And do we provide kind of coaching and support around this is how you actually get better? I've never met a physician that sat through a class on how to improve their HCAHPS
That's
score.
a great point, Brian. I just finished an arrangement with a hospital, and they had a year to work on it, and the doctors did not achieve a single metric or earn a single dollar that was offered to them under that quality contract. So I wanted to ask you, kind of, if you had to create a short list, what are the things that contribute to success, and what are the barriers that create failure for these initiatives that strive to improve quality?
So from a success standpoint, I mean, I get back, does everybody actually understand what we're doing? Not that we're entering into an arrangement and we'll figure it out. Does everybody understand what we're doing? Do you know the assignment? If we don't know the assignment, I don't care how narrow it is or how broad it is, you're not going to get buy-in. You're going to have passive participation. And once it goes live, we're going to shift our energies and attention to the next shiny object.
Observation. I think you have to have a very strong physician champion.
And they become a champion by understanding.
I hadn't thought of it that way, but understanding and through that getting support for the initiative is what's critical to make it work. What else do you see as, I mean, you've had some of these succeed and some of these fail, so what most commonly cause them to fail?
Well, let me start with why they fail, because that's more common. Or fail is a strong word. Why they don't achieve what everybody wanted to achieve. And they principally fail because no one understood it. They didn't really understand it. Like the difference between a rote employment agreement or PSA is we're just buying a physician's sweat. We're buying their time. We're not buying how they go about it, how they sweat, how they think about kind of modifying their care or practice patterns, et cetera. So understanding it. But they also fail because we didn't design it in a way, and then once, to your earlier comment, Jim, once we get signatures, everybody moves on to the next project. Did we actually support it so it can work? Is it getting the necessary medical administrative support? Do they understand how it's going to work? How do we keep physicians engaged? Do we give them feedback so they stay engaged? I mean, most physicians I know, they want the type A personality, like they want to succeed. And you give them the feedback and we're transparent about it, they want to succeed. However, we've defined that. We designed it so it could actually work in our organization. We supported it, and everybody actually understood what we were doing. The number of these complicated arrangements we see, really layered PSAs, once you bring in all the attachments and exhibits and this big enterprise-wide, not like VBE enterprise-wide, but enterprise-wide, the amount of people who don't actually understand what we were doing or not doing is shocking sometimes. A year in, these things weren't implemented. We didn't do this. And then, Steve, you know better than anybody, you're then called months later or years later and being asked to fix something that has Stark and AKS implications because of how we already paid it out, how we haven't paid it out. Can we correct this? Is it adjustable? And a lot of that's a byproduct of no one understood and had poor implementation.
It's an interesting observation that failure is due to a lack of understanding. I worked with a hospital to build a network. We'd been at it 6 months or 9 months, and then one of the doctors stands up and says, "So I don't understand. When are you going to buy my practice?" So he'd been at all of our meetings, and he didn't take away any of the messages we'd been delivering, which is we want to focus on quality, we want to focus on care coordination, we want to focus on reducing cost.
Because the mindset is, once you buy my practice, then it gets a little bit of autopilot, and I can just practice normal sinus rhythm. And I'm going to take a step back. Let me even before all that, truly, and this sounds, so listen, I'm an aspirational guy, so I get it. This feels kind of big. But truly how these things work is that leadership, administrative and clinical, already sets the vibe or the tone in the organization that quality matters, and that's what we're achieving for. Okay? So you have to have the temperature in the room has to already kind of be there so that it makes sense. Otherwise, it's kind of a one-off thing.
There has to be understanding and commitment, right? It's a cultural change.
Yes, it's a cultural change. And this is going to sound like an indictment, and I don't mean it this way. I mean it with respect and affection. But a lot of business leads who run point on many of these alignment initiatives don't understand clinical operations the way they should. Like, how will this work in the hallway tomorrow at noon? How can a physician not actually execute on this? What is impeding a physician's ability to do this? And there's a big gap there, and partly touches on that knowledge issue. But there's a big gap there.
So, Brian, I think that's a perfect point to have you comment. You know, when I talk to folks about what's different with VBE, I use examples, lots of different examples, but the example of the service line co-management agreement, right? We're paying docs an hourly rate to think about how to deliver care in a more efficient way, in a higher quality way, in a way that provides better patient satisfaction. And that's an hourly rate. And so they're sitting at their desk thinking about that. They're wandering the halls thinking about that. They're engaging with staff thinking about that. And we're expecting them to do a timesheet at the end of the week. There is no way that really compensates the physician for the work she does thinking about those service lines. Right. And so VBE gives us a chance to think about that differently, to say, we're going to pay you based on outcomes. We're going to pay you based on profit sharing. We're going to pay you based on shared savings.
Trying.
Just putting together a plan, even if it fails. VBE allows us to pay for failure in an effort that was well worth trying. Give us your thoughts on how that changes the game.
Let me add a layer to that. VBE allows us to pay a physician for the way they want to practice. And so in a brainstorming session, in some respects, that's one of the questions you start with. Once we free ourselves of really strict adherence to notions of volume and value, and we really look at value, if you could redesign the system, the program, how you care for that disease state, how you care for that patient population, what is the optimal way for you to do that? Let's set aside how we get reimbursed for it for a second.
And you're asking the physician, what is the optimal way?
Yeah.
You're not asking the CEO, you're not asking the CMO, you're not asking the CFO, you're certainly not asking the general counsel. What's the optimal way we deliver quality care? That's what you're asking.
Yeah, it's what you're asking. And so in some respects, you're helping them kind of design their independent study program, if you will, where you design your master's degree here. I mean, that's a big part of the consideration because you get a lot of buy-in when you do that. And then you stress test those ideas against actually what's doable and what's achievable. Like, is there a flow of funds? What does it involve? What are our gains unrelated to flow of funds? Patient engagement, kind of disparate access to disparate populations that otherwise weren't prioritized because their payer mix was bad.
Even, Brian, ancillaries. I mean, all the things we would have panicked over in the past, right? We can bundle these as total returns on a service line. In a way, I mean, Steve, you're one of the nation's leading experts on compliance, right? We have options that we never had before.
I think the value-based enterprise rules give us a lot of flexibility we didn't have 5 years ago. We can pay for quality in ways we couldn't. We can pay for coordination of care in ways we couldn't, because it allows us, I liked your expression, Brian, it allows us to pay for results. We're not buying sweat. And the old way of building quality was to pay for sweat. We'll pay you as a medical director. We'll value the outcome by the hours you put into achieving the outcome, which is not the right approach. So I feel like now we have some new tools to work with.
Right. And it gets back to the demystifying it sort of issue, because in some conversations when this concept, you hear what somebody's challenge is and what they're trying to do, and the response is, this is ripe for a VBE, given what you just said your goals are. And often it's like, well, hold on a second. We don't want to build this multi-million-dollar enterprise with a governance structure and it's 5149. I'm like, no, full stop.
That's not the point. That doesn't get us where we need to go.
Yeah, I mean, if you wanted to over-construct something with a lot of layers and sophistication, you could. But we can also do this, by a letter agreement with two physicians who take this specialty clinic, and there's a lot of opportunity there. Right. We could do it a lot of different ways. We just need it to be, authentic.
And we can only do that if we're focused on quality and we're really delivering care that meets the patient's expectations. So, Brian, I want you to look into the future. President Trump has said he wants all Medicare beneficiaries and MA plans. Other changes are happening. What do hospitals need to do with a focus on quality, coordination, and cost? What do they need to do to get ready for the healthcare that's coming in the next 5 years?
So that you just mentioned the big caveat, which is the next 4 years, where is the energy and investment expertise? Where is that going to sit? There's already been discussion that several CMMI programs that are not regulatory but are desk policy may get undermined a bit. And so that's where some of the incentive is at to do these things. MA products are good vehicles for those things, but they have a lot of discretion what CMS allows them to do in terms of kind of structure, what essential benefits are there, and that sort of thing. So this all assumes that we trust, in fact, that we will continue to move away incrementally or in substantial steps away from fee-for-service, such that we have to figure out how do we maximize the return on outcomes, engagement, et cetera. Again, the caveat, I don't know what the next 4 years are going to, how CMS and HHS are going to operate. But I think it will continue because Social Security Trust Fund says it has to continue for all practical purposes. I think consumerism is not going away. Community will always expect that we do better and that they have got a great experience and that we actually make progress with chronic disease management and preventative care. So assuming that's where it will continue to go, even though healthcare leaders want to see material money behind it to adapt their service lines, we still have to invest right now in how we engage physicians and support physicians to provide optimal quality care. So that means we've got peer review systems that can measure it, that we provide feedback on it. This applies in every setting or situation. And it's one reason why we don't really achieve what our goals are anyway, because we don't do that part well.
And that part is giving physicians feedback on their performance. Is that what you're saying?
Yep, we capture it in a program that's going to be recognized by every state's peer review statute for confidentiality purposes. We distribute it to them in a transparent, actionable manner, and we have clinical leadership that herds them to where they need to be. You either herd them through a VBE, or you herd them through privileging criteria, or you herd them just through feedback and the arms race who wants to be top of the list. But you herd them any number of ways. That gets back to the lens on how I see these things. For me, that's where it begins and ends. And when physicians know you're serious about it, they will then align with you on some of these initiatives to do that where there's money involved. They just will, because they'll have trust and confidence in it.
Are you hopeful?
I am. I actually am. Only because there's enough of a groundswell of individual expectation. The industry lags a little bit from kind of where communities are and where the public is. And people are generally more engaged, getting better. That expectation breeds and spills over into other things. Payers reluctantly will get there. When CMS speaks, the big payers listen. But I am, because I think it's inevitable.
There's going to be change. There's tremendous cost pressure. These are some tools we can work with to really change the direction of healthcare. Yep. Thank you, Brian, very much.
Well, Steve, that was a great episode. Great guest. Why don't you tell us about our next guest we've got lined up?
Jim, our next guest is Amy Mackin. She's a shareholder at Hullrender. She spends her time working on managed care contracts. She's going to talk to us about how providers can do a better job of negotiating and give us a checklist to work from to do a better job at getting terms you want on your payer agreements.
For our audience, more information about the podcast, you go to our website, which is howhealthsystemswork.com. And from there, you can subscribe in either Spotify or Apple or any of your favorite podcast platforms and keep track of upcoming shows and find information on past shows.
Thanks for listening. We'll talk to you next week.